outside and thank the organizers for giving me this opportunity. And the next 18 to 20 minutes, we'll have an interactive session on the most important topic like neuroimaging for the intensivist. One, what is the need of this for the intensivist? Because anyhow we are having the radiologist. Yeah, because you're the person who is taking care of continuously the critically ill patient. So they are there, but in the out times, out of office hours or in night duties, because if you know this basic understanding of imaging and all that, you will be more helpful to take care of the patients in a proper way and do a good quality of care. For example, if you assume that a patient who has presented with acute ischemic stroke in the window period, if you know the proper understanding of that imaging and the mass effect and the probable deterioration, you can give a better work, better care for the patient. So we'll go through this topic in the following subheadings: introduction, and we'll go for the interpretation of the CT scan. We'll conclude this session with going through the few case examples, because in this span of 20 minutes we cannot go into the depth of this other imaging techniques like MRI and all that. So commonly used modalities in neuroimaging is CT scan as well as CT angio, CT perfusion scan as well as MRI, and utilization of this ultrasound also by doing this optic nerve sheath diameter as well as a transcranial Doppler to know the blood flow in the brain. So coming to this planes of this CT scan and MRI scan. So while doing in a normal CT scan, there what usually follows is the gantry angulation. What is gantry angulation? So gantry angulation is nothing but it's a direction between the gravity as well as the radiation. So while doing only CT scan, it is being applied, not in the MRI. So why it means in this gantry, because of this gantry angulation, what happens is the there is we can avoid the bony tissue, maximum bony tissue within the image, as well as we can reduce, in order to reduce the dose of radiation to the eye, this gantry angulation has been implied. So because of this, what happens is the topmost scan which is taking the last, it will be posterior to the vertex. But this plane is not, the planes are normal in case of this MRI. So what about the CT brain? CT brain is the computed tomography is nothing but the combination of X-rays, the focused X-ray beams and directed array and a computerized production of this image. So what exactly means attenuation? Attenuation is nothing but when the X-rays is passing through the tissues. The tissue which hampers, which attenuates the most, appears the brightest. For example, because this attenuation is expressed in Hounsfield's. The who is having the tissue who is having the highest attenuation will appears as the brightest. For example, the bone is having the highest Hounsfield's, that is 1000 Hounsfield's. It appears the brightest, whereas the water is having the 0 Hounsfield, and egg is having a negative, so negative minus 1000, so that it appears the black. So yeah, just to have a look over this CT scan, what we are observing here is the CT scan. We are having three colors here. One is the brightest one, which is having the highest attenuation. The tissue which is having highest attenuation is the bone. The brightest is bone. The other one is gray matter, white and gray matter. That is the parenchyma, and then the black one is the CSF. That is having, the black one is having around the 0. This one, this CSF, which is water, having in the Hounsfields of 0. So that's why it's appearing black. It's appearing black. So other than these three colors, one is the bright white, the gray color parenchyma, the third one is black color CSF. Other than this, we have to consider the two more things. One is a relatively brighter within the parenchyma. Relatively brighter, what we call it as hyperdense within the parenchyma, hyperdense. Not like this too much brightness as this bone, but less than that is blood appears like a bright inside the parenchyma. And in between this, not black like this, the other color we'll see this black, not black, it is in between black and this gray. Then that color, if it is present in that zone, so we call it as infarct. So both the two things, one is infarct on the CT appears as hypodense, and the blood in the parenchyma appears as hyperdense. So just can you kindly mention the parts here? The one is, yeah, anterior horns of the lateral ventricle. The two is, yes, two is around the third ventricle. The, yes, three is the basal cistern. The four is the vermis of the cerebellum. So in the left side of this image, the right side of the image, the other image, what we are seeing is, yes. So the, yeah, CSF is there, some sylvian fissure. So the, behind the sylvian fissure, the lobe which is having the temporal lobe, and this one again, this third one is basal cistern. The fourth one is midbrain, and fifth one is around fourth ventricle. Fourth ventricle. Just two. And as an intensivist, we should concentrate on the two slices. Two slices. One slice at the region of basal cistern, the other slice at the region of the foramen Monroe. So because here we have a lot of vascularities as well as the cisterns in this structures. So if you know this slices, we can have a the best diagnosis like the narrowing of the basal cisterns where there is rhizodicity as well as the acute peritoneal herniation as well as the posterior cervical infarction. So the other region of where we should have an idea is the region of foramen Monroe. So what happens is here the most of the midline structures are we should know all the structures on the midline and also the vital structures like caudate nucleus, thalamus, lentiform nucleus, and all these things we should know. So what are the most common MRI sequences which usually follow? There are four sequences. One is T1. T1 is for evaluation of normal anatomy, and here the CSF will be black. The T2 image, this is used for the detection of pathology as well as some edema, vasogenic edema and acute bleeds can be diagnosed here. Here CSF will be white. And in the flare sessions, fluid attenuated sessions, the flare session, here the CSF appears black, and here we can know the white matter abnormalities as well as periventricular lesions. The fourth one is usually the diffuse weighted image where the acute infarcts are seen. Acute infarcts can be detected in the diffuse weighted images. So how are you going to differentiate this MRI and CT? As you are all knowing that MRI, we are having the advantage is it is with no radiation, no ionizing radiation, and also it can use it to detect the soft tissue injuries. Whereas the CD advantage of the CD, we know that is a less time, and easily we can less cost, less time, and easily we can shift the patient. Whereas in the MRI, we should have the patient is having any pacemakers and all, we cannot allow here. So when you are at the bedside, because you are being preoccupied with some patient pathophysiology, that the patient is having patient is having some left hemiplegia, so you have to concentrate on the lesions on the right side. So while you are going through this interpretation of the CT scan or MRI, you should go in a problem-oriented approach. For that, we are having some mnemonic. You can follow the mnemonic like blood can be very bad. Yeah, sorry. So this is a mnemonic. The blood can be very bad. So first of all, you have to see that is whenever you are going to seeing the scan. After verification of the patient details as well as the clinical history, you want to check for the blood. After that, you have to check the cisterns. After that, brain parenchyma. After that, you have to go for the ventricles. And after that, finally the bone. So coming to the blood, how the blood is going to appear on the CT scan. As we already discussed in the first slides that blood appears bright, not like bone, but relatively less than the brightness of the bone. So it's having Hounsfield of around 50 to 100. So as the time progresses, within 1 to 2 weeks, if it goes around merges with the brain parenchyma, merges with this hypotensis merges with the brain parenchyma, and as the time progresses, this goes into hypodensities. Within 2 to 3 weeks, it goes into hypodensities. So depending upon the localization of the blood, it can be defined as an epidural hematoma, subdural hematoma, and subarachnoid hematoma, intraparenchymal hematoma, as well as intraventricular hematoma. So coming to this extradural hematoma or epidural hematoma is this, most of the patients will be associated with head injury. There is the collection of the blood in between the inner structure of the skull as well as the outer structure of the dura. So this is a lentiform. This appears in the lentiform biconvex shape. Usually it's an arterial bleed. It's most surgical emergency. It's usually arterial bleed. 75 to 70% is because of a medial meningeal artery bleed. And when compared to the subdural hematoma, subdural hematoma is a chronic venous bleed. Venous bleeds is because of oozing from the bridging veins. So this crosses the suture line, and it is like a banana shape or crescent shape like that. The overall prognosis is poorer than when compared to the epidural. So here what happens is it is collected in between the dura as well as the arachnoid matter. So the blood has been collected in between the dura as well as the arachnoid matter. So in case of chronic subdural hematoma, because recently one of our colleagues, grandma, has been admitted. Because what happens is that she's an elderly female patient who is a known case of post-PTCA using the antiplatelets. So in this patient, some trivial trauma has occurred in a couple of days back. After that, the patient gone into drowsiness and altered sensory. When we have got a CT, the CT has showed like this, because this is what we call as the second CT, both the white as well as darkness is there. That is acute on chronic SDH. This is a continuous, because if you compare this density with this CSF, it's not such a black, but it is like relatively less than that. It's a chronic SDH. This is a chronic SDH. This is because of the slow continuous venous oozing after minimal head injury. So here this is a acute and chronic component, because both the whiteness is also there as well as the black shades are also there. So for this case which has happened in our ICU, so our neurosurgery team has passed as per hole. After that the patient has improved. So coming to the intraparietal bleed, that may be traumatic or because of the spontaneous. Spontaneously maybe because of, most of the times it is because of hypertensive bleed. Most common hypertensive bleed is the region of basal ganglion. After that maybe thalamus, pons or lobar cerebellum and cerebrum also. So here this the other than hypertensive bleed, what we call as is in elderly gentleman, if the patient is having a bleed, then we can think of the amyloid angiopathy. So when at the bedside, when we are seeing this image with the blood, we have to concentrate on the site as well as how it is crossing, creating the mass effect, as well as the intraventricular extension. If this patient is having intraventricular extension and creating the hydrocephalus, we have to go for the EVD also at the bedside. Involve the neurosurgery team and go ahead with the EVD. And this is a subarachnoid hemorrhage. We can identify the image of subarachnoid hemorrhage by knowing this, identifying this blood in the subarachnoid spaces like circular Hillis here, and in case of Sylvian fissure. Here in the initial period, the sensitivity of the CT scan is around 90 to 95%. As the time progresses, the sensitivity decreases to 30% within 2 weeks. So yeah, here is one case for your presentation, because we are having an intervention neuroradiologist, a dynamic person, because here is a 32 years old male presented with sudden onset of headache and vomiting. His CT scan has showed the blood, blood in the subarachnoid space, and the CT angio has been done here, which has shown the ACOM aneurysm. And this is the pre-coiling image, which is showing the wide neck of ACOM aneurysms. Our intervention, the neuroradiologist has passed this coiling here. After this coiling, the neck has been obliterated. Okay. So this patient has improved. The another second case is this is a 65 years old hypertensive female patient with unruptured giant right paraclinoid as well as small cavernous segment aneurysms. For this, what he has done is neurointerventional radiologist has done is he has avoided the flow through the aneurysm. He passed the flow diverted and also created the partial coil. Because of that, the aneurysm has the blood flow has been diverted from that vessel, so that vessel has been collapsed as well as the thrombosed by causing this coilings, and this patient is improved. So coming to this extracranial hemorrhages, because in a trauma patient we have to observe regarding subtle fractures where there is having a maximum soft tissue impact, and also underlying parenchymal contusions also. We have to concentrate as well as COUP as well as counter-COUP injuries also. And after the blood, we have to concentrate on the cisterns. Cisterns are nothing but the CSF, the potential spaces of CSF collections. So there are main four systems, that is circummesencephalic system, where we have to concentrate on this, and the supracellular system, because here the supracellular system and ciliary systems. If there is a blood in these systems, it shows the importance that it is a possibility of aneurysmal bleed. So we have to concentrate on the systems, and if these systems are getting compressed, there is a possibility of razor IST also. So we have to concentrate after the checking of the blood. We have to concentrate on the systems. After the concentration of the systems, we have to go through the brain. How is with the brain? Brain is a non-homogeneous structure. As we all know, it's a non-homogeneous structure because of the gray and white interference. And the cortical and gyrus ulcer pattern should be present. Otherwise, there is a possibility of cerebral edema, raised recipient cerebral edema. So whenever you got a acute ischemic stroke patient in your ICU, so what is your main aim in performing the CT scan? Yes, yes. So the first main aim is to exclude the hemorrhage. The second is to differentiate between the dead tissue as well as one is irreversibly damaged tissue as well as the reversibly damaged tissue, which can be improved by saying this, by maintaining the perfusion. One thing is that, the other one is to identify the stenosis or occlusion of the major extra and intracranial arteries. So in this way, we are selecting the candidates for the thrombolytic therapy or thrombectomy patients. So this image shows the left MCA infarct, where we are having this dead tissue in between, which is irreversible, and the surrounding tissue is the penumbra. This is the reversible tissue, reversible damaged tissue. If you can go ahead with early resuscitation and whatever may be, depending upon the time situation, window period, thrombolysis or thrombectomy, the patient may improve, the perfusion may improve in that penumbra region. So what are the earliest signs of CT scan in the ischemic stroke, in the ischemia? So here, yes, because whenever you see the hypoattenuation on the CT, it shows that irreversible brain damage. So here the first and foremost change is hypoattenuation of the brain tissue. The other one is the obliteration of the lenticular nucleus. The third one is, the earliest sign is the dense MCA sign. Dense MCA sign is nothing but there is an accumulation of the clot in the vessels, and then it shows as a dense MCA sign. The fourth sign is insular ribbon sign as well as circle effacement. So after that, knowing the infarct, we have to know which vessel is getting blocked. So after that, we have to see the perfusion scan. How is the perfusion in the brain parenchyma? Here is another case, 48 years old male, which is post MBR on anticoagulation, and brought on the prosthetic valve, developed dense left hemiplegia with altered sensorium in the hospital. So initial diffuse weighted image has shown some little bit change in the lentiform nucleus as well as the temporal lobe. When we have done this perfusion scan, pre-procedure MRI perfusion scan, there is a diffusion perfusion mismatch is there. We have gone for the MRI, there is a disconnection of right MCA. So after that, we have done the intervention radiologist has done the mechanical thrombectomy and recanalized. The perfusion has been restarted. After 24-hour scan, this shows there is the perfusion mismatch is not there, as well as there is a establishment of small infarcts, but the vessels has been recanalized. Reperfusion has been established. And after completing this brain, we have to concentrate on the ventricles. How are the ventricles? Is the ventricles are dilated, or is the ventricles are having any obstruction? There is development of hydrocephalus. It may be communicating or non-communicating. After that, finally, we have to concentrate on the bone window. How's the bone window? In the trauma patient, if it is having any depressive fracture, any comminuted fracture, any linear fracture, or any because of the injury to this master cells and all that, there is a possibility of penetrating injury. There is a possibility of inserting into air into this brain. So because of pneumocephalus, developing neurocephalus, we have to concentrate on that. So after all going through this interpretation of the CT scan, so how you are going to, just we'll have a view on how you are going to utilize the ultrasound. This is another method to see the raised ACT, because this is optic ultrasound, because eye is a superficial structure with internally jelly-like material. If you place a probe gently on the eye, you can have a clear image of the internal structures. So regarding this optic nerve sheath is because this optic nerve is surrounded by optic nerve sheath. In between optic nerve and optic nerve sheath, we are having CSF. So because if the CSF, if any change in the raised ICP in the brain, that CSF pressure is transmitted here, and this optic nerve will get bulged. So by measuring this optic nerve sheath, we can know the raised ICP. What the studies have suggested is, because here usually linear probe will be used, but you should be very gentle while keeping the probe on the eye. You should have an adequate use of the jelly. So if you take the 3 millimeters behind the globe and measure the optic nerve, if this optic nerve sheath diameter is more than 5.7, more than 5.7 millimeter, then it indicates that the ICP is more than 20, more than 20. And if it is less than that, the ICP, the possibilities of ICP having more than 20 is less than 5%. That is nothing but it's having a more negative predictive value, more negative predictive value. Okay. So, because by doing this optic nerve sheath diameter, because if the patient is sick at your bedside, if you are suspecting any rise in ICP, you want to take to the MRI or CT, then bedside, this is a non-invasive, no radiation, no ionizing radiation. You can do it repeatedly. You can do it repeatedly, and you can use the anti-edema measures and to decrease the rise in or CP also. And the other method is transcranial Doppler ultrasound. So this is a new modality which is recently using that to see the blood flow to the brain and within the brain, as well as it can be used for the for knowing this vasospasm in the case of subarachnoid hemorrhage, as well as in the sickle cell patient, blood flow in the sickle cell patients also. So the only one major limitation is we cannot accurately locate the vessels through the vault. That is the major limitations. So just to have a few examples, here is a 50 years old gentleman who is a known case of diabetes, hypertension, smoker, presented to our institute in altered sensorium, aphasia and right hemiplegia. What we are observing here? Some hypodense area, a large hypodense area in the left MCA. Yes, the midline is maintaining, but the systems are getting compressed. So what is the possibility? Yes. So yes, acute ischemic stroke, left MCA infarct with mass effect and raised ICP. Yes, here is a 60 years old gentleman. Here is another film, like 60 years old gentleman, laborer having a long standing history of smoking, now presented with headache, vomiting and seizure. What happening here? Yes. So yes, we are having a huge irregular defined hypodensity within which we are having some hyperintensity, we are having some calcification or bleed irregularly, and the maximum edema is there. So possibility of you have to think of any tumor with mass effect. We have to confirm with the CT, contrast CT. So here's the other film, like 33 years old female patient, known case of type 1 diabetes with a history of long standing CSOM, now presented with history of fever, headache, seizures and altered sensorium. So what are the possibilities? Here is a hyperdense lesion with yes, it's an ill-defined hyperdensity with various amount of edema surrounding. And when in a contrast CT, it is showing as a ring enhancing. So more in favor of abscess. So here is recently this boy has been treated in our ICU. 25 years young gentleman met with a road traffic accident and had tibia and fibula fracture of the lower limb. After 48 hours, brought to ICU in acute respiratory distress, hypoxemia and altered sensorium. So on examination, petechia was present in the palpebral conjunctiva. What this image is suggestive of? There is having a punctate white dots in the basal ganglion, and centromobile and all this. So which is appearing like a starfish appearance. So which is more in favor of cerebral fat embolism syndrome. Yes. Here is a 35 years, the other film, 35 years old gentleman who is a chronic alcoholic brought to the ICU with the history of seizures and altered sensorium. On examination, the patient is severely dehydrated with anemia. So this scan shows some filling defects here. Okay, some filling defects. So this is more in favor of CSVT, superior sagittal thrombosis. So the other gentleman, other films, like 70 years old female patient, known case of diabetes, hypertension, obese, CAD, post PTCA brought to our institute in a state of unresponsiveness, on ventilator. After having CPR for 40 minutes, ROAC attained. Hemodynamic is stable. So here in axillary flare lesion, the hyperintensity is in the basal ganglions, and also in the bilateral symmetrical posterior hyperintensity is in the diffuse weighted image. So more in favor of yes, yeah, excellent. Hypoxic encephalopathy. So to conclude, various modalities are available to monitor the neurocritical care patient. Most common is CT scan. Interpretation should be in a problem-based approach. So ultrasound has become the stethoscope for intensivists, which is a non-invasive, non-ionizing, which will be more helpful for predicting the raised ICP. As an intensivist, we should have proper idea, knowledge about the pathophysiology of the disease and all the imaging and monitoring system along with the most important clinical examination.